Um, as a good rule of thumb, we generally don't treat long head of the biceps because we don't look at it as a primary pathology. So I won't throw, I never love the idea of stim and ice on someone who has anterior shoulder discomfort. I think that's a total cop out that overlooks the fact that there's tons of differential diagnoses that could be in place. So as a good rule of thumb, we're trying a lot of other stuff. In the rehab cases, we work in conjunction with physical therapists on, and with guys who just have kind of chronic biceps tendon soreness after they pitch. For us, usually you'll see more like biceps muscle belly type soreness in guys who are really aggressive into elbow extension when they throw. But you will see some guys who have some trigger point referrals from biceps to kind of like a subdeltoid bursitis presentation, so almost like the middle deltoid. And you'll see some guys that will get some biceps referral to the superior border of the scapula. But there are a lot of boxes you have to check before you start cranking on a biceps tendon. Going to a biceps for soft tissue work, to me, is premature because you may in fact be treating some protective tension. That biceps may be cranked on because the cuff is weak or the scapular control is bad. It could also be that you have some of those nerves at the front of your shoulder that we talked about that may just be really really irritated. And you're working on those. It's not actually the biceps. So what are some of our differential diagnoses? Well, first off, true tendonitis, an inflammatory pathology, is actually pretty rare. If people really had biceps tendonitis, some anti-inflammatories, whether it's oral or injection, is going to calm it down pretty quickly. And as we know, most of the time, tendonitis is not that easy to get rid of. So we're dealing more of a tendinosis, so degenerative changes where tissue loading has exceeded tissue tolerance. So we need to work on modalities to improve it. We need to redistribute basically stress to take some of the wear and tear off of that particular muscle. So, your differential diagnoses are going to be, could be some cuff stuff. Cuff will refer down the anterior shoulder. It could be your biceps tendon, the attachment on the labrum. You can take anti-inflammatories until the cows come home. But if you have a SLAP 2 lesion where your biceps tendon is pulled off your superior labrum, it's not going to help. It could be thoracic outlet, nerve symptoms, basically stuff both proximally and distally further down that just happen to present at the front of the shoulder. Could be a capsule injury, which are definitely no fun. That could be a traumatic one. It could also be basically one that's a little bit more chronic in nature. You'll see anterior capsule plications for throwers whose shoulder ligaments in the front are too loose, and as a result, it's kind of like a marble rattling around in a glass jar. You can get referred pain from trigger points all over the place, whether it's subclavius, scalenes, pec minor, you name it. Lots and lots of stuff will refer stuff to the front of the shoulder. Bursitis can present that way, so it may be a little bit of an inflammatory problem that doesn't have to do with your biceps. Latent teres major are really significant because of their attachment points. They both attach a little bit further down on the humerus as compared to the rotator cuff. So when you have those kind of attachment points, you'll actually see people who have lat injuries or teres injuries that actually may be misdiagnosed as having biceps tendonitis or some other kind of pathology in the front of the shoulder. So those can be missed. Pec major is another one. Certainly it comes up in kind of the same region as where latent teres are coming in on the anterior aspect of the shoulder, so or of the humerus, I should say. So pec major is a differential diagnosis. In a younger population, you have a proximal humeral growth plate. It's kind of how we develop the retroversion that we'll talk about later on in the lab portion. But a lot of people will mistake that bony injury in young kids as biceps tendon problems, and they give them stim and ice, and it doesn't go away, and they keep throwing, and eventually it winds up being a more pronounced growth plate injury, classic little league shoulder. And certainly in an older population, arthritis, right? You can have degenerative changes to the joint. Someone may be a candidate for a shoulder replacement, but if you keep calling it biceps tendonitis, you're going to really miss out. So I never love the biceps tendonitis diagnosis, whether it's from an actual ortho or whether it's an athletic trainer who just pulls out of their back pocket, in a pinch when things are busy and they wanted to kind of quickly calm down a situation. You always want to dig deeper because usually that anterior shoulder problems are coming from something else. And and certainly in a baseball world, we see guys who have faulty mechanics that make the anterior shoulder sore after they throw or give them pain. So you have to look at a lot of different factors to sort things out.